Uh, Good evening, everybody who have joined online and also in-house. So I welcome you all for this webinar on clinical challenges in management of geriatric psychiatric disorders. So I would request everyone to mute their mics to avoid any disturbances. And because of paucity of time, it might be difficult to attend all the questions, but I request all of you to put your questions in the chat box. We'll try to address whatever is feasible during the time. So without further ado, I would request Dr. P.T. Shivkumar, Professor and Head Geriatric Psychiatric Unit under the Department of Psychiatry, NIMHANS, for welcome address. Thank you.
Good evening, everyone. On behalf of the Geriatric Psychiatry Unit, Department of Psychiatry, NIMHANS, so it gives me immense pleasure to welcome you all for today's program, discussing about the webinar about clinical challenges in management of geriatric psychiatric disorders. First of all, I would like to welcome the chairpersons, Professor Matthew Ageism, who is the former head of the Department of Psychiatry, as well as the founder of the Geriatric Psychiatry Unit. Thank you very much, sir, for accepting our invitation and being here today. And Dr. Srikala Bharat, who's again former professor of psychiatry at NIMHANS, and also the founder of the Geriatric Psychiatry Services at NIMHANS. So thank you very much, ma'am. Madam was not able to come here in person, but she joined online. So thank you very much, ma'am. And a lot of our collaborators who have been helping the geriatric psychiatric services from psychiatric social work, clinical psychology, with various other multidisciplinary team, nursing, and a lot of people play a role in both our clinical activities as well as training and research activities. A lot of collaborations we do for research as well as training. So I welcome all of them and also take this opportunity to thank them for the support what they have extended. And we had an overwhelming response for this program. A lot of people have registered and who are joining, and the participants include people from psychiatric background, clinical psychology, or psychology, social work, nursing, and few other people who have expressed interest in attending this program. The idea of today's program was to give some kind of orientation about the challenges what we face in our clinical practice, the profile of people whom we handle, and how the geriatric psychiatry services have been functioning, what are the role in terms of training, research, various programs what we are doing. We wanted to kind of orient people for that, and also discuss some of the complex cases as an example of how learning in geriatric psychiatry and understand the challenges, how the services are functioning, and what resources we have and what gap we have, and how we can actually provide a good quality service and training as well as research. So that was the main purpose of holding this program. And many of the people who have joined online, I would also take this opportunity to welcome you all to kind of our Vayomanasa Sanjeevani initiative, which I'll be talking about briefly later, and where we are doing a lot of outreach and awareness kind of activities. So this program is something like arranged in a very short notice, and hopefully the kind of enthusiasm and interest shown, people please stay through, and then I think you will kind of get to see the actual learnings that can happen from different cases what we handle. And my team will be presenting some of the case scenarios what we handle, and we'll discuss about those things. Feel free to ask questions, and you can chat. You can actually convey your this thing. So we'll try to take up the discussion. So I welcome you all for today's program, and we'll go to the next. Thanks.
Thank you, sir. I request Professor Matthew Varghese to provide introductory remarks.
Good afternoon, good evening, everybody. As Dr. Shivkumar said, the Geriatric Psychiatry Services has held for many years awareness and educational programs. And these kind of awareness and educational programs are extremely required for not just the public, but also professionals, because it's important to tell professionals also about geriatric psychiatry and what it involves. And this is very important because of the huge geriatric or old age problem that all of us know are upon us. So with this in mind, there are various programs that the unit does throughout the year. And we also have online educational programs, for example, in the ECHO, in the certificate programs, which actually people can join. And in addition to the Vayomanasa Sanjeevani program, which Dr. Shivakumar spoke about. So this initiative is something which is very welcome, and I welcome all of you for this program. And I know that there'll be many more programs like this as we go along through the year. So thank you very much and welcome.
Thank you, sir. I request Dr. Shrikala Bharat ma'am to provide the introductory remarks.
Yeah. Good evening to everybody, and thank you for inviting me. I'm sorry I'm not able to join in person because of some emergency. I think healthcare needs and requirements and concerns change with the demography of the population. Since the elderly population, for various reasons, because of the healthcare and the death rate being low, increasing over the time. For example, in 2021, 13.8% of our population are elderly. Can you hear, PT? Yeah, so are elderly. And I think this is a population which is going to grow exponentially and will have, and all of you know that their requirements towards the healthcare is very, very high. And so it is very, very correct and needed that an institution of national importance like NIMHANS and the Geriatric unit is providing not only awareness, or also peer learning. Clinical peer learning is one important method of understanding what is the state of art advancements, and also how to deal with some of the very difficult clinical issues. And these clinical issues need not be only clinical. It could be, social, socioeconomic, familial, cultural, and they all influence the clinical picture of any elderly who presents. And it could be other physical and health issues also. So I'm happy that today we start our program with the case discussions which address some of these issues. And it would be a very good learning experience for not only people who are in NIMHANS, who get to see a variety of cases, but also people who are joining in a webinar. I see nursing and social work, people have joined. It would be a very good peer learning and discussion forum for such an exercise. So I hope it is helpful to everybody. And thank you again, PT, for this initiative. And I think these initiatives are very much needed. Thank you once again.
Thank you, sir and ma'am, for summarizing the relevance of geriatric psychiatric services. On that note, I request Professor P.T. Shivakumar to discuss about geriatric mental health services and training and research in NIMHANS.
Yeah. Thanks, Varshita. So what I will be doing in the next 15-20 minutes is to kind of give you a glimpse of the profile of our clinical services and what kind of people we handle, what are the challenges, what we face, and what kind of activities and training program that is going on, some glimpses about research. As Dr. Matthew and Dr. Shrikala highlighted, I think geriatric services is something which is kind of evolving. There are not many centers actually which provides dedicated services, unlike child. If you see, there may be many psychiatry centers which may have a special clinic which is fully operational. If you look at geriatric services, how many services actually give full-time geriatric services to my knowledge, there are only two departments or two units which provides. One is NIMHANS and one more is Lucknow, which has super specialty teaching and also a kind of dedicated kind of program for geriatric psychiatry. And not many places the special clinics are there. Some are memory clinics are run in as part of some of the departments. But if you look at the Mental Health Act, there is actually a mandate to start old age psychiatric clinics services and child psychiatric services. I think this is a special population. It needs a dedicated service. There is also a Maintenance Act for senior citizens where there needs to be a separate kind of or dedicated services which is to be available. And the population now is increasing from already many of the states like Kerala is already beyond 15%, 16%, almost reaching 20%. Globally, if you look at the entire India, you look at already crossed 13.8 crores, and which is going to only go up. We will almost reach 20% by 2050. When we look at the genesis of geriatric services at NIMHANS, I think Dr. Matthew and Dr. Srikala were visionaries in the sense that they started it way back in 2000, when I think not many, even general geriatrics, not much of importance is given. Even now only the ministry is actually starting up various regional centers of aging and then National Center for Aging. The importance of geriatric medicine itself only growing now only. So 2000, I think 1999 was the year of elderly. And that gave an impetus to start geriatric services, and 1066 Dementia Research Program was one of the other activity which probably stimulated this one. I think way back in NIMHANS, Dr. K. Srinivas had initiated, and I think if I'm right, it's 80s and somewhere it was 90s it was initiated, but it didn't sustain. But we now see the beginning of the geriatric services as 2000, because from that time onwards it's running. And 2017, we became a full-time independent unit under Dr. Matthew Verghese as a head. And that's when earlier it was a part-time, half-a-day clinic. I joined as a resident in 2001. That time the clinic used to be, there are hardly 10, 15 people used to come. We used to wonder as to why this clinic is kind of, what is the importance of this clinic. But over a period of time, half-a-day clinic used to have 100, 150 people, it crossed. And then we used to go back at 8 o'clock the night. So that is the kind of demand it created. And then subsequently it became, I think starting the DM program gave the impetus to necessity to start a full-time unit. And now our resources are not very big, but we have a dedicated team of faculty from psychiatry, as well as we have senior residents and fellowship students. Some of these things, I think people may not be aware that we have a fellowship program in for social work and psychology. We have a fellowship program for people who have psychiatric nursing background. So which is still a lot of awareness is not there. So one of the reasons why we also kind of continuously engage with the stakeholders is to kind of to bring awareness about these opportunities for training, so that people can benefit and also the services can benefit. So social work is another department, I think, which has given a lot of importance to elderly, and we have full active support in terms of consultant as well as other PhD scholars and junior consultants. And we get part-time support from other departments like psychology and nursing. I think we are all hoping to expand these resources once there is some more, because everybody is, the needs for elderly when it is increasing. I hope we will get support from the administration, from other departments to strengthen our resources so that we can provide more quality care. And one of the ways how we think this can be done is also about a lot of training opportunities. NIMHANS being a training institute, I think our strength is our trainees. They are the main workforce. And once we have all these training courses fully running and expanding, I think we will be able to cater to the needs of more people. The vision of our services is to become a center of excellence by implementing clinical services, training, research, and advocacy of global standards in the field of aging and mental health. We are not talking about only disorders. I think there's a lot of emphasis now given in terms of prevention, promotion, healthy aging. I think mental health cannot be distinguished separately from physical health. I think as psychiatrists and geriatric mental health professionals, whether it's a psychologist or nursing, I think there is a lot of role to play in those kind of aspects also. So we as professionals will not be dealing only with acute care. right from prevention to rehabilitation. There is a role for all professionals, and I think the multidisciplinary team who are trained in geriatric will be required in future more and more when this population becomes significant. So our vision is to develop these things, including advocacy, where the government as well as other organizations which are involved in geriatric care, we should be leaders in this so that we can actually augment the capacity, not only in NIMHANS, at a national level. We are trying to do that in our own way. Dr. Matthew and Dr. Shrikala had initiated a lot of things, and we as followers, we are following those things in some aspects, and we hope to grow more over a period of time. And looking at the clinical services, we have first contact outpatient services on a daily basis, which is again, I think there's no other center which has this level of service, as I said, where there's a dedicated team which is available every day, and then looking at initial evaluation. And we also have detailed evaluation, follow-up OPD, and a separate focus on dementia. I think our department is the psychiatry services and geriatric psychiatry services at NIMHANS is a only center which actually deals with lot of number of dementia patients. If you look at the profile, most of the centers it's handled primarily by neurology team, and very small numbers when behavioral problems are addressed by psychiatric colleagues. But here, I think from the beginning, our unit has been involved actively in dementia-related work, both in terms of clinical services as well as research and training. So that focus we are still maintaining. And acute care inpatient services, I think, is grown dedicatedly now. Our inpatient numbers have increased, and emergency services, again, it's quite busy. So these are all the range of acute services, clinical services what we have. Apart from this, there is a neuromodulation, which again, there are role like TDCS. We do both in terms of, say, people with cognitive impairment, and RTMS, again, for depression, and people sometimes even with cognitive impairment, we try. ECT is one of the mainstay. I think globally, if you look at geriatric psychiatric services, ECT is very much used in elderly because of a lot of intolerance to medications. I think that is true in our practice also, and we have published it earlier in terms of what kind of practice has been there. But I think the ECT practice again has changed quite recently, and we need to document those things. A lot of research. My colleague Dr. Preeti Sinha is an expert in ECT, and she does a lot of research and with respect to ECT in general as well as ECT in elderly. And I think that is one of the strengths here. A lot of people, even sometimes we have given ECTs in OTs, where a high risk kind of a patient, where it has to be given with OT with a necessity of some resuscitation options available. So we have gone to an extent where we have given in OTs, and people from admitted in other ICUs, medical ICUs, have come and taken ECTs. So many of the centers we find a lot of hesitancy in advising ECT in elderly. But on the other hand, globally, ECT is one of the main important mode of treatment in elderly. Particularly, you will be listening to people where there's challenges in medication intolerance. That's where ECT can be a much safer option than medications. And other non-invasive brain stimulation is emerging as an option, including the possibility of a domiciliary kind of interventions where TDCS can be given at home. So there are research going on, and our TDCS team, Dr. Venkat, has been leading a clinical research center, and they have actually developed TDCS machines, which in collaboration with DRDO, which probably will help us to give TDCS at home of patients in future. So we are quite keenly working towards those things. And I think COVID has taught us a lot of things has to be done in through tele, including this program. But tele-geriatric psychiatry, even before COVID, our unit have been actively working with the community services and telemedicine services. And we have been doing that proactively follow-up, and it has been published in in the Journal of Geriatric Mental Health for initial experiences on tele-geriatric psychiatry. And I think subsequently, one of the opinion papers we have also written in Indian Journal of Psychological Medicine. I think that is COVID has given a lot of boost to tele follow-up, and we are more comfortable now doing therapy and video-based evaluations, which is going to remain because challenges of people coming to in-person consultations is going to be difficult even during normal times, and that is something which will grow in strength in future. And when Dr. Sikla had initially mentioned, it is when it's geriatric, it is not only medical, a lot of psychosocial issues, complex psychosocial issues, including legal issues and various other challenges what we face. And we have a good support system in terms of a very strong social work team, which is part of our service. And also, this is where I think cutting across the boundaries of our expertise, I think we might have to be sensitive, and then we might have to reach out, whether it's a psychiatrist or a psychologist or a nursing. I think unless we are sensitive to the psychosocial needs, we will not be able to give a holistic care. I think that has been the way how I have been oriented. And I think a lot of times solving their basic psychosocial needs can actually augment their care and well-being much more than any other medication. And I think those kind of approach, I think everyone should have as a part of multidisciplinary team. And when it comes to institutional care, old age home, I think, is growing in numbers. There are not much of dedicated old age homes are available for people with mental health, particularly destitutes. And we have been working with collaborators, with organizations which are providing support for destitutes, persons with mental illness. And as a trainees, I think it's very important for us to gain that experiences and what happens in an institutional settings. I think without that, our training will not be complete. So that is why we have actually networked with organizations where we visit some of the organizations, but we provide a support on a continuous basis for some of the organizations. And I think it works both ways well, where we can actually contribute to their care, as well as we also can learn from that experiences. I think that is something we have initiated, and which is, I think institutional care, mental health is going to be an important issue in future. And that needs to be, that's again one of our strengths where we are doing active work in that. Psychological assessment and interventions. I think therapy, if you look at geriatrics, I think whether there are a lot of challenges in doing therapy, which is sensory impairment, how elderly are amenable for therapy. I think that is again some area where we have been getting some support from psychology department, as well as in-house our psychotherapy program, what we have for our residents. We are able to do something. I think this is one area we need to further do well in terms of providing access to psychological and psychosocial intervention to more number of people. Without adequate resources, it's difficult to do. And I think resource constraint, how many people actually need psychosocial interventions and how many are able to get it, if you see, there's a very minuscule actually gets. And that is because of the constraints what we have in terms of services. How do we do it? We have actually come up with some ways where at least a simple psychosocial support can be given through tele by a less trained people, what we call as a task shifting or a task sharing approach. And that I think globally has been proven as one of the ways how psychosocial support and services can be taken to people where it doesn't need always doesn't require a high level of training to give a basic level of interventions. So that again, our team has been evaluating on a pilot basis some of the options for telepsychosocial support. My colleague Dr. Preeti Sinha developed a portal, and she had we are evaluating it. Hopefully, in the next year, probably in the next couple of years, we will be able to scale it up with more support. And legal services, I think every patient nowadays we start to view with the prism where there is what is a potential legal angle. In a lot of property disputes, children having problems with parents, and abuse, elder abuse, physical abuse. There is very serious physical abuses sometimes we face, neglect and abandonment. All those things, issues are very common in our practice. And the government has actually brought elder helpline, which is now available. I think all of you should know there is one common number, which is 14567. I think this is very, very useful kind of number, where it is available across the country. In multiple states, it is already functioning. I think more than 23 states, it is already functioning. If you just call this toll-free number, anybody can report a problem and it is registered. And subsequently, there is a team available even at the districts where they can actually visit, and then they can actually provide support in terms of psychosocial support, and various grievances can be solved. It is not just about, it can be when a missing person is there or somebody is abused, the rescue and rehabilitation and placing in an old age home. It can be facilitating some of the crisis with the family. They can do dispute resolution and some kind of grievances they can address. and mediation they can do. With the police also and legal system also, there is some role. And we have collaborated with Karnataka State Legal Service Authority and been running a free legal services clinic. So all these things, I think we need to keep in mind when we talk of a geriatric psychiatric services. Without these things, it will not be possible to provide a comprehensive service. Now, what is the scale of our services? Last year affected by COVID, this is the numbers from the last year's clinical records. We have an electronic record system, fairly accurate number, but I think there may be some issues in terms of disruptions and things like that. But by and large, this is the numbers what we are having, around 3,000 new patients despite COVID in the last 1 year from April to March, and more than 5,000 plus follow-up visits. I think a lot of people think we do now tele and as well as video conference. And which is it? No, it's 300 plus admissions. I think admissions have definitely increased in the last few months post-COVID. A lot of people who have come for admissions. A lot of complex cases, sometimes they require admissions for even evaluation. And that is something like which we have. And emergency visits as well as mental health care, we provide support for around 100 plus residents in the old age home. We provide mental health support. We have large number of people from 60 to 69 age group as well as 70 to 79 age group, but a considerable number of people less than 60 and 80 also, more than 80 also we see. We include young onset dementias, some people with 50s with late onset depression. We by and large we see dementia or cognitive disorders of any age, and people with 80s now have actually increased. We see even up to 95 people are started coming for consultations, and centenarians are also not a very, there are people who have come of 100 years of age. So I think the longevity is going to increase and in future. So we might see more and more people of older world with a lot of frailty, with medical comorbidity. In terms of gender distribution, it's more or less equal distribution of our services. And in terms of diagnosis, I think we have a very considerable number of proportionate, almost 25% is dementia, and depression and anxiety forms a large chunk of our profile, and subsequently bipolar, psychosis, other disorders like insomnia or various other psychiatric, neuropsychiatric disorders we see. And what are the challenges? Just to give a glimpse. So one is the increasing demand. How do we face with the resources, and how do we kind of address these issues in terms of the resources, what we have, and the demand, what we have, how do we manage and maintain the quality, and the complexity in clinical presentation diagnosis. If you look at the numbers in adult and numbers in geriatric, each case, it takes double the amount of time for us to actually do some justice in terms of understanding multiple kind of psychosocial issues, legal issues, medical issues. So the complexity in clinical diagnosis can be challenging. Overlap with medical comorbidity and sensory impairment. The challenges in interviewing people with mask, it's even more, and they cannot understand many times. So these are all complexities in elderly population. And intolerance to medications, lot of side effects they develop. So we need to be very careful in choosing medications. There are people who come with 20, 25 medications in a list. So we first have to kind of compile all the medications, what they have been taking from 2-3 doctors. We don't have a concept of family physician for most of our patients. So it's all specialists, from gastroenterologist to orthopedician to cardiologist. Everybody have 2-3 vitamins. It's together to compile that and then to make a sense, and they will be following their own prescription. What is written will be there. What is given may be completely different. So we need to actually compile and then do that. It takes a lot of time. I think nursing is a big role in that. I think if we have nursing support, I think many of these things can be addressed, where making people understand the prescription, understanding what they are giving and educating what they have to follow itself is a big task in these people. And complex psychosocial issues and ageism, I think they come with a more severe problem. It would not be surprising to kind of neglect this as normal for aging. Even person with a severe behavioral disturbances or severe decline in their functioning in a short period of time, a simple UTI might be ignored as a normal for aging. Anyway, this person is dementia. It is okay for the person to be incontinent. So attention is less. So that is one thing. And there is a need for caregiver intervention and support systems. And without those things, we can't actually just prescribe medicines and send. So a lot of intervention, our time goes with caregivers. And we need multidisciplinary care. it is not enough for psychiatrists to do. That's why we are trying to strengthen our resources with social work, psychology, nursing, and maybe we need speech therapists, we need audiology, say physiotherapists. So we need to strengthen our team so that we can provide, including nutrition, I think is one of the important issues we don't address. So these are all, we need to form a multidisciplinary team, and NIMHANS is fortunate to some extent we have this resource, but we need much more resources to provide even and improve our quality of care. These are all human resource and time intensive care. So that is, I think these are the challenges what we have. And we have been working on some plan to improve constantly. And one of the program is going to launch shortly is the Dementia Seva program, which promotes volunteering. I think many of you might have attended our orientation program for this recently. And ICSC Securities have given a CSR grant for us to encourage volunteers, from including students as well as senior citizens, who can be trained and who can help our services. And this, even things like translation, it can be an active engagement for a senior citizen who is healthy and who can actually benefit by the constructive work what he is doing. And our services can benefit by having a translators, because we see patients from across the country. So our trainees are also from across the country. So the language barrier is an important barrier for us in terms of what we provide service. And I think that is something which we are working on it to get some volunteers. And strengthening, I already talked about strengthening our multidisciplinary team and case management approach for some selected patients, where we can do an intensive kind of management and then learn from that experience. Also provide, everybody doesn't require that, or we may not be able to offer that kind of service for everybody. So we have been talking about it, and I think maybe in the next year we will try to formalize this case management approach. And that is one of the plan what we are having. And I also already talked about enhancing access to psychological and psychosocial intervention. And the demands what our people have, many of the people may not be able to wait for sufficient time. They have real issues in terms of continence, in terms of pain. They may not be able to sit in waiting time. How do we reduce the waiting time? How do we reduce the convenience of our people who are attending? And I think that is something we are working on. We just today we had a discussion with one of the funders who said that they will give some CSR support for patient care coordinators to actually implement an appointment system which requires a dedicated support to guide the patients and improve their convenience when they attend the clinic. So these are all things which require a lot of efforts. And elderly friendly infrastructure, we are hoping that the services what we have can be improved by providing some more additional elderly friendly infrastructure. All my team are asking for additional space. We are a lot of space constraint is there, and it's not elderly friendly many times. So we are discussing with our administration as to how to do that. And every space, for example, whether it's a OP or IP, I think we do have a lot of issues of falls. I think we need to pay attention to the infrastructure is one of the important things where we need to pay attention. And we are working on those things. Electronic records, I think our team, Dr. Preeti, has been leading that. We already kind of implemented in outpatient and maybe in inpatient as well as emergency and outreach. When we have a training setup, again, that is something which where to kind of have an oversight on all those things, what is happening. Electronic records is one of the important ways how we can ensure some kind of quality and some kind of oversight mechanism. That is again, it is going to be developed further for emergency and inpatient in the future, and also for outreach services. So few major initiatives that is going to come up is a specialized dementia care unit in as part of the specialty block. It's already in the advanced stage of construction. By next year, we should be having that up and running, and that will have a dedicated dementia ward kind of a facility, which will give a more which will give opportunities for us to do group work with the caregivers. So a focused kind of interventions can be done. We are also coming up with a residential care center in our outreach campus of Sakalvara, that already a CSR grant of 10 crores have been given. We are just working on the proposal to implement that project. And caregiver support, way back we had been doing it. Because of COVID, many of the interruptions have happened. And now one of my doctoral scholar from social work is doing an online support group. She is actually evaluating this. And hopefully in future, we will have a regular online caregiver support group will be available, as well as in-person support group for people who are able to come here. So I think that is something. And we are working on geriatric medicine support. I think that is something, visiting consultant, we have already got appointment, and hopefully we should be able to improve that support, because a lot of consultations in medical comorbidities we face. I think one area where we haven't had a major success is community-based services and daycare. I think that is something maybe in the next 3 to 5 years, we hope we should be able to have some progress. So coming to training, I think we have several training courses, which it's a very important focus for today's program also. We want people to know more about these courses. Fellowship, postdoctoral fellowship we initiated in 2014, and DM's Geriatric Psychiatry in 2017. There is also 1-year fellowship course for geriatric mental health care for MBBS. This is anybody with MBBS background can actually appear. It will give 1 year of exposure as a resident. It can be for even MD medicine or DPM. Anybody can apply. So even sometimes DNB or MD person also can apply for this. So fellowship in psychosocial care for elderly is open for social work as well as psychology background, those who have master's degree in social work and master's degree in psychology. And fellowship in geriatric mental health nursing, these are all 1-year fellowship courses, collaboratively implemented with the other departments like Department of Psychiatric, Social Work and Psychology, as well as Department of Nursing for mental health nursing, which again is eligible for people with MSc Psychiatry nursing. So what are the salient features of these courses? It will give an opportunity of clinical experience and training in a multidisciplinary team. I think it's not just a theoretical kind of course. It is a practical experience, a hands-on experience can be there, and they can get a work experience certificate. A lot of people who would need a work experience certificate, this can be an opportunity for handling people with a complex disorders and mental health disorders. Exposure to a whole range of mental health issues, right from prevention to rehabilitation. And networking and collaboration with major organizations. We work with multiple organizations like Nightingale's Trust, HelpAge India, Artsy, say Tata Trust. Many organizations we discuss and we collaborate with them. So those kind of networking, and even CSR organizations which work, elder care is a focus, like ICC Securities or REC Foundation. A lot of people have opportunities where they're implementing programs, NSE Foundation. So all these things, people can get exposed how geriatric services are run by various organizations. And opportunities to get involved in training and outreach initiatives. And also some amount of, if they are motivated, they can actually learn some research methodology and possible publications. And we do provide guidance and mentoring for career in geriatric mental health care. I think that is something which is going to expand for all these disciplines in future. And I think there's a lot of opportunities which is coming up. So some of the major training initiatives other than the regular courses is one we have been implementing with the National Stock Exchange Foundation, is a national initiative of skill training on dementia and mental health for caregivers of older persons. This is currently planned to extend it for next 5 years. We have applied for the grant. And this has been training geriatric caregivers who are paid caregivers at home or in institutions. Either as upskilling or to identify unskilled people, untrained women who have up to 10th standard education, and then provide training for them in a hybrid mode as a geriatric caregiver, and with a specific focus on dementia care. And this is something which we are planning to implement in collaboration with Artsy. The funding agency is National Stock Exchange Foundation. And there's a huge demand for caregivers. A lot of our patients avail services from paid caregivers. Without training, they have a lot of difficulty in handling the mental health problems. And this is one initiative which has a big promise to kind of address that gap. The other part of it, a lot of delay in diagnosis happens because the physicians are not sensitive to the diagnosis of dementia. My colleague, Dr. Preeti Sinha, had actually worked on this module a few years back and conducted one batch of training in collaboration with the ECHO project, and then Dementia ECHO program was done successfully. And now we have got a donation from a charitable trust to implement it in a regular manner. So that again, we are going to have dedicated staff who will be running this training program for physicians. And with the volunteers, again, we intend to launch a certificate program for geriatric mental health literacy, which will again a short training program on a hybrid or an online, primarily online kind of a training with some volunteering exposure in person or online. So that will help them to get this certification of a geriatric mental health literacy. So everybody should be knowing about the problems so that in their own personal life or their families, somebody can recognize the mental health problem and then be a kind of a person to guide them. So that is something which again can be an important training opportunity. So we do have a learning management portal and which can help in this training. as well as networking with various organizations for joint academic programs, which we are planning to do it in a much more rigorous manner, and some skill-based workshops for our own trainees. We've been doing on something on imaging we have been doing, and there are many more areas where we will collaborate and do enhancement of training in these areas for all the multidisciplinary team in future. So some of the major research projects, which thanks to our very strong collaborations, one of the things where Dr. Matthew and Dr. Sanjeevani was leading is the ADBS project, which is a very large project funded by DBT, where dementia, Alzheimer's is one of the focus. And recently we have got a grant of my colleague, Dr. John P. John, who's heading the imaging laboratory here, has got a grant on India Enigma Initiative for Global Aging and Mental Health, which is going to look at a 5-year project where various neurobiological mechanisms of neuroimaging things, measures have been going to be done for dementia, including our collaborations in the Ayurveda as well as integrative medicine, as they have a center of excellence in the integrative medicine, and they have got Alzheimer's dementia as one of the focus to develop to evaluate the treatment opportunities in integrative medicine, as well as understanding the neuroscience behind the integrative medicine concepts. So that is something, again, a major research project funded by the government of India. There are several other things which we are not listed. These are some of the major initiatives which are kind of contributing to the research, and several doctoral research proposals ranging from biomarkers to interventions and psychological interventions, caregiver aspects, and wandering behavior. So various things we've been doing, and sleep issues again, which have been doing, in COVID-related things as part of our DM protocols. So several research initiatives are going on. Lastly, the outreach initiative. I think we started in October 2020. This Vayomanasa Sanjeevani initiative is something which has kept us in a continuous engagement with senior citizens and public, and many referrals have started coming through that. And also we are in a lot of people have helped in conducting a lot of awareness programs on aging and mental health on a regular basis. In Kannada and Hindi, this is going on. And also we have a small group in Tamil. And if you look at the objectives, we are actually working on many of the objectives, right? From age-friendly community, we had started a program with Legal Service Authority and started an initiative called Age-Friendly Karnataka. And a lot of things what we are doing to improve the services comes under the ambit. And promoting awareness we have been doing, and training of volunteers we are doing, and interventions in old age homes we are doing. Integrative medicine, already we are collaborating and doing some service as well as research activities. So telepsychiatry, all these things we are doing, we have named it as Vayomanasa Sanjeevani initiative. And this has been going on. And so telepsychosocial support, which I talked about earlier, is one of the important things what probably will get scaled up in future. And some of the important donations which for Dementia Care Center, I would like to take this opportunity to acknowledge and thank REC Foundation for this, and which 40-bed center is going to come up in Sakalvara. And we we're trying to actually expand it with more additional funds. And Professor C.R. Chandrasekhar, I would like to acknowledge and thank him for generously donating 1 crore for maintenance expenditure for our center, for the upcoming Dementia Care Center. And the Vayomanasa Seva, or the caregiver training project, is again a CSR project funded by National Stock Exchange Foundation. And here, as I told already, that the training of caregivers is being done, paid caregivers is being done. And even the training of dementia care, dementia for physicians, again is a CSR grant. And the volunteer initiatives, again a CSR grant. So we have been using this resource to promote our services. And lastly, I think we got recognition both in terms of state government as well as central government a few years back in terms of research as well as clinical service. So we still have a long way to go. I think the foundations laid by Dr. Shikla and Dr. Matthew, I think the team working currently, myself and Preeti and my colleagues, other supporting kind of colleagues from other multidisciplinary team, as well as our trainees, I think we have a responsibility to take it forward maybe in the next in the next decade or so, to kind of scale it up as a center of excellence. And I hope we will, with all your support and this one, we will be able to expand these clinical services, training opportunities, as well as research in a much more kind of in a manner in which will serve a larger number of people. Thank you very much.
Thank you, sir, for that well-articulated presentation on role of geriatric services, need for multidisciplinary approach, and also the importance of training and upscaling our resources. So, sir also emphasized on clinical challenges in geriatric psychiatry patient management. So that could be further discussed in our case discussion. I would like to invite Dr. Thomas, working as a senior resident, as a DM resident under geriatric psychiatry, for case discussion.
So good evening, everyone. As we have already discussed, and Dr. Matthew sir as well as Shivakumar sir has alluded to the fact that geriatric psychiatry doesn't just cater or restrict itself to only patients more than 60 or 65 years of age. Rather, we also look into the most important aspect, that is the neurocognitive aspects, and therefore major neurocognitive as well as minor neurocognitive disorders, which comes in the ambit of the mainly neurocognitive disorders, actually is also an important population which is catered to by the geriatric psychiatric team. So just to give a flavor or an essence of what we actually see and some of the patients who come in at a very young age. So for example, we have one patient. He's a 38-year-old gentleman who studied up to SSLC, right-handed. He was basically working as a weaver from rural Tamil Nadu. So he primorbidly had features of suggestive of cluster C traits, mainly anxious, avoidant kind of traits, and family history of multiple first-degree relatives having features suggestive of major neurocognitive disorder. There was significantly poor understanding by the family about the illness, and there were a lot of negative expressed emotions, mainly hostility, criticality, and emotional over-involvement was also seen. And there were significant interpersonal issues between the patient's wife and the mother, which also hampered the patient's condition. So the personal history was that he was married since past 13 years. There were no habits. He used to take a mixed diet. And past medical history of hypothyroidism, which was detected more than 6 years back when he had the initial symptoms. And it was initially thought to be of due to hypothyroidism, but subsequently because of multiple factors which I've discussed before, he had very poor compliance and even the medications were not given timely. So he had presented with a history of 6 years of insidious onset, progressive illness, which was characterized predominantly by behavioral problems and later cognitive deficits. The behavior problems were mainly significant apathy. And followed by that, he also had developed poor attention and recent memory deficits as part of his cognitive decline. Subsequently, he had impaired instrumental activities of daily living since past 5 years, and he stopped working as a weaver and he was sitting at home. And also his basic activities of daily living started deteriorating since past 2.5 years. Along with that, he developed significant mutism, aggressive behavior towards the wife, often causing a lot of physical injury towards her, and also perseveratory behavior, double incontinence with significant biosocial-occupational dysfunction and unmanageability at home. So with this profile, he had come and we had evaluated. The vitals were normal. He had marfanoid habitus, and there was a thyroid swelling which was seen. And the mental status examination revealed that he was quite disheveled, poorly kempt, quite agitated with poor speech output and irritable affect. So being a patient who was much young, usually less than 65 is the cutoff age when we say, which distinguishes early onset versus late onset dementia. So here is a patient who was only 38. So we had to do the entire panel of dementia workup, which included imaging as well as the other specific tests like HIV, VDRL, and other specific tests like the autoimmune panel and the paraneoplastic panel, as well as the vasculitic workup. So when this was done, the imaging was suggestive of a diffuse atrophy. As we can see that the coronal images doesn't suggest much of a temporal, medial temporal atrophy as well. And family pedigree chart shows that multiple relatives. Actually, the reason for him coming to us was that his younger sister had similar kind of illness and she passed away 1 month before he actually came to us. So that was one of the precipitating reasons why he actually came to us. And one of his elder sister also suffers from similar illness. She was also evaluated after we diagnosed this condition. So with which detailed workup was done. And here is the need for actually sending for a genetic workup. A whole exome sequencing was done. And it revealed that he had autosomal recessive kind of illness based on the CTSF gene mutation. So he had what is known as the CUFS type B illness, which is a form of neuronal ceroid lipofuscinosis. And there are two types of cuff disease, type A and type B. And in type B, they usually present in the adult onset with dementia with motor symptoms. And it is seen that the incidence is almost less than 1 per 1 million. So it's that much rare. And they had initial symptoms of behavioral change, psychosis, and the median survival is 12.6 years after diagnosis. So this was the case which we had actually seen. So coming to the main aspect is that what are the challenges we encounter in almost all patients with neurocognitive decline, and especially in patients with who are young as well as have a familial kind of dementia. So one is the access to pathways of care. So initially there were issues in diagnosis, there was misdiagnosis, there was delayed diagnosis, partial diagnosis, giving that only hypothyroidism was identified and subsequent identification with respect to his neurocognitive symptoms were not done. Then there's a role of autoimmune illnesses which complicating dementia. I told that the patient had thyroid swelling. And when we actually checked the anti-TPO, antibodies were quite high, more than 1,500. So because of which it was also identified that he could also have something known as Hashimoto's encephalopathy, which is steroid responsive. So steroids were also started. But then there was also adverse effects of this immunomodulators, which is something which we all need to understand. Steroids by themselves can also induce psychosis as well as mood disorders. So these are some of the challenges with respect to treatment. Now coming to the model of illness which the patient and their family had is more of a magic or religious, because majority of the family members, 3 out of 4 members had the illness. The parents did not have the illness. So how could it be possible? Their explanation was the neighbors have done some black magic, and because of which they have actually taken treatment in terms of magic or religious kind of interventions outside, which did not help them. And significant psychosocial issues were there. There were IPR issues between the in-laws and the patient's wife, which would actually result in a lot of kind of resistance to care. And it could actually bring about a lot of issues in terms of actually caring for the patient, and a lot of expressed emotions, which I had already described were there. There was significant caregiver burden. The wife was significantly burnt out. And the 2 children that the patient is having are of 13 and 8 years of age. Their future and their care is also something which has to be considered. And being from a situation where they are from social economic status being in the lower side, from the below poverty line, it is of significant financial constraints. For every small treatment, they have to travel to their nearest town, which is about 200 kilometers away. So these are financial constraints which also came as a roadblock to the treatment. And significant stigma, because they are from a village background. And not only that, many people would actually complain that this family has a lot of patients with mental illness. And then treatment related challenges. I've told about the pulse steroids, which actually improved the anti-TPO titers, but there was no significant improvement. That means there is an underlying neurodegenerative process which is going. And then the role of second generation antipsychotics, which should be given only for aggression and agitation and some psychotic symptoms. That also did not help. It actually caused more extrapyramidal side effects. Role of SSRIs, especially when there is significant stereotypies, apathies, but actually there is only grade B evidence with respect to that. So something which helped actually is the ECT, which I think Shivkumar sir had alluded to before. So ECT is something which actually reduced his aggression and agitation to a great extent and improved his attention also. And then once it was done, we also tried to give him actually the newer modality of transcranial direct current stimulation to see whether it would have some kind of improvement of his cognition, and that could actually help. Along with that, the most important thing I think in a patient with dementia with behavioral and psychological symptoms are the behavioral management strategies. And the ABC analysis is what will actually give an idea and then help us to kind of give the patient as well as the patient family an input with regard to management aspects. Now, the challenges are a lot, the rehabilitation related challenges. Now, he is only 38. Can he be accommodated in an old age home, even though he is having dementia? Can he be put in the community? Or who will take care of him? If his wife is taking care of him, what about the loss of wages? Who will help her? Who will help the family? So these are some of the challenges which are there and which need to be addressed in such a case. So with this, I think I have given some idea with respect to young onset familial form of neurodegenerative disorder. And I think we can move ahead with the discussion part.
Thank you, sir, for bringing up this case. I request Dr. Thomas has already brought up that this patient is young onset. He presented at 38 and symptom onset was by 32. There was multiple family degree, first degree relatives who had similar issues, and we have arrived at a specific diagnosis in this patient. So I wanted to know, how did you arrive at this diagnosis and what was role of genetic testing and counseling in this patient?
So in this patient, so here in this patient, genetic testing is which had helped us to actually clinch the diagnosis. And this could be because of multiple reasons. One, because it's young onset and familial form of dementia. And most of the young onset dementia, we have to think about the possibility of a heritable form of dementia. And because he was quite young and a lot of behavioral problems was there, we thought of phenotypic frontotemporal type of dementia. So that was one of the important reasons which prompted us, because about 10% of frontotemporal dementias are hereditary in nature. So that is the reason why genetics was planned and whole exome sequencing was done, because multiple family members also had similar picture. So when genetic assessment was done and we got the CTSF for the cathepsin F gene mutation, we understood that this was a problem related to Cuff's disease. Now, why do we have to do genetics? Is because there are different types of genetic tests. One of the most important one is for diagnostic genetic test, which was done here. And there is something known as testing for vulnerable population, as well as something known as a predictive testing. When there is a family history of dementia and the non-affected family members, we can undergo the genetic testing. So in such situations, as per the American College of Medical Genetics, it has been told that diagnostic testing is quite important, but predictive testing can only be done if it is given the consent by the non-minor population. So these are some of the recommendations. But I think in such cases, young onset familial dementias, and definitely if it is having a behavioral variant of FTD phenotype, it's always better to go ahead with genetic testing. And that will actually give us a diagnosis, which will be helping us to actually guide them in taking an informed decision with regard to further care and management.
Thank you, Dr. Thomas. I would now request Mr. Puttamare Gowda, who is a junior consultant in Geriatric Psychiatric Unit, to he has also worked on this patient for management of psychosocial aspects, to provide his inputs regarding the psychosocial management for this patient.
So, good evening, one and all. This patient was brought for a diagnosis and evaluation at our geriatric clinic and evaluation. And I was not there for a first when they got admitted. I was able to see them in the second IP care, and this is the third IP care currently we are having. And the psychosocial issues, mainly we found that one is the care management. Especially we used to say KAP, the knowledge, attitude, and practice. As our senior resident Thomas has clearly told, they had a poor knowledge and also attitude and also magico-religious of practices, especially the family of origin of the patient. They couldn't able to go with the how to support the system, especially the wife was the primary support. And also the couple of our family sibling also had a early onset of dementia. They also felt very difficulty to get the things is done, especially the treatment cost. We used to say that direct cost and indirect cost. So direct cost is mainly due to the medical treatment. At the same time, that will also burden to the additional cost, like indirect cost, when the caregiver have to leave their job and she has to stay back here, and a lot of couple of burden, especially she had the wife has to taken care of the very early childhood. They are going school going children, and she couldn't able to know that where to keep the children. At the time she was seeking the help of the family of procreation, And because that family in-laws, no, they were unable to understand the symptom and they couldn't able to accept the medical model of treatment. At the same time, they had IPR issues with the caregiver, I mean, primary caregiver and in extent wife. So that's why she was struggling a lot. One is the financial as an area of burden. At the same time, the support system, especially the family of procreation, couldn't able to understand and help her. At the same time, when she look at the family of origin, they are also not in a position to help her, not only in the emotional support, some instrumental support also was seeking because she was the tailor and she left the job because of to provide the catering the services which is need for the her husband, the patient. At the same time, and also we found that the patient sibling, she also got early onset of dementia and she got admitted. And many time what will happen in a government setting or wherever they go for a treatment, no, they used to have some documents that will help them to get the government benefits or hospital benefits where they couldn't able to get it because they had a poor access to the documents. And that has made them to get the basic welfare benefits what they can supposed to get it. For example, we have Aishman Bharat scheme, and also we have in Karnataka state, we have a BPL status. Those are all required basic document like Aadhaar card, the BPL ration card, along with that sometime income certificate or Ayushman Bharat card. These are the documents couldn't able to access because they are from another native part of native state of Karnataka, main Tamil Nadu. So those are the difficulty they faced and they brought to the PSW consultation. We tried to help them get it all the documents done. At the same time, we discussed with our administration to consider on a humanity ground and look for a geriatric fund. It can be helpful for them during the IP care because they couldn't able to uh, provide the care as at the same time the financial constraint. They couldn't able to pay the money and they were requesting for do the needful. So that time we discussed with our administration, hospital administration, with especially RMO and medical superintendent. They really cooperated and they told that these are vulnerable group. We are there for the helping. And now we are able to make them disability certification related issues. They couldn't able to get a UDID, and we are help them to apply for a UDID and get the disability certificate related things. And also Ayushman Bharat, now they are able to enroll and they got a income certificate related to BPL status. So those are the things are able to help them when we are working as a multidisciplinary team. And along with our senior residents and our MPhil scholars, we are able to educate them about the illness and better practices, especially the care management area, where the patient may require a lot of rehabilitations options. When they go back to the hometown, the caregiver may need alternate caregiver support. That's why our brothers and all came to help her. And so many times the role of advocacy for her to get into the job. So those are the things we are able to help them out. And we also got good support from our geriatric clinic and services team. And many times we discuss with our consultants, psychiatric consultant as well as psychiatric social work consultant. That is the things. Any questions are there, we can also answer later. Thank you.
Thank you. Now I request Dr. Matthew sir to, so in this patient, we had given ECT for some of the behaviors like aggression and agitation. I request sir to give his comments upon the role of ECT in handling behavioral disturbances in such population.
Hello. Yeah. So I think ECT is not something that you would commonly give in people with dementia, mainly because the person has got a cognitive disturbance. But it is recommended only when aggression, agitation, psychotic symptoms are not, we are not able to tackle them. Usual practices that we follow in terms of giving antipsychotics or benzodiazepines. So if there are some rare patients where we might have to resort to a very brief course of electroconvulsive therapy, we don't usually give what is usually given in depression in terms of 6 or 8 or 10 ECTs, but we give just a couple of ECTs so that the
aggression, the agitation, or the acute, very belligerent symptoms are taken care of. That is really the indication. Otherwise, ECT is not generally indicated as a first-line treatment for any behavioral and psychological symptoms. I just had another comment on or a question to Dr. Thomas about the case itself. When you are seeing a person this person was actually 31 when he started the illness, isn't it? And there's very strong family history in the same generation. His sibs two of his sibs having an illness. So, and the illness is starting in the 4th decade, not the 5th decade. Ordinarily, 30s means 4th decade. Usually FTD would start either behavioral variation or the language variation would usually start in the 5th decade, in the 40s, and commonly in the 50s. So what is more than FTD as such? What would you really think of in this 30s as a diagnosis more than FTD? FTD is a general diagnosis in which you have to rule out a whole bunch of conditions, including depression, including psychosis. FTD by itself is diagnosed, the degenerative version of the so-called original Pick's disease of frontotemporal dementia is diagnosed when you rule out a whole bunch of conditions, including vascular conditions, head injury, toxic conditions, infective conditions like neurosyphilis. So only then you diagnose the typical degenerative FTD, which is again very specific. So in the 30s, what would you actually think of is my question.
It could be including like psychosis, like a schizophrenia kind of illness, which would be there. In this patient, the things which we had thought of considering FTD is actually the 3 siblings or 3 people in the same family having the illness. The eldest lady having the sister developing the illness in her 4th decade, and also the role of heritability. So these are the 3 things. And the things which we had actually looked into considering is considering dementia as a possibility is because the significant functional decline, there was double incontinence, as well as there were some frontal features like significant apathy, which was usually seen. However, it is not discounting to the fact that usually in the 3rd decade, on the early 2nd decade, on the late 2nd decade, we think of a primary psychiatric illness as one of the most important possibilities, as well as neurodevelopmental problems. Yes, sir. So storage disorders definitely is one of the important possibilities. But he didn't have any other signs, because usually we get on clinical examination, we get hepatosplenomegaly, or we get some eye signs, or we would get even mental retardation or IDD, which is one of the most common kind of symptoms. For him, he was told to be absolutely fine till about 31, 32 years of age, which was also slightly odd considering the possibility of a mucopolysaccharidosis or a glycogen storage disease. However, this was also considered because we felt that the family, there was also extrapyramidal kind of symptoms in the elder sister. So which was also going in touch with an FTD, PD kind of picture. Get the subcortical symptoms also were there. But after the genetic confirmation, when we went and read about literature, definitely neuronal ceroid lipofuscinosis is also kind of a mimicker of a storage disease. And it also presents with a similar kind of phenotype. But the Cuffs disease type B presents more with dementia and extrapyramidal kind of problems. So that is how we are able to reach the diagnosis.
I think one of the point I want to add in this patient is that ECT, we would not have considered generally when we think of 6 years of illness of dementia, it's already in a kind of severe advanced stage. He had, but a lot of crying spells kind of thing. And also he had the food intake had just deteriorated. and it was a kind of a crisis to feed him. So we thought of depression as a comorbidity. So that is why where when we gave a trial, actually to our surprise, actually more than our expectations, actually he had improved remarkably well in terms of feeding, and also some of the ADL actually improved. So even in a person with dementia, depression as a comorbidity is something which we should not miss out. And you cannot reverse the dementia, but the what is the impairment due to depression could reverse. And there are a lot of progress now going on, including I think in depression and dementia, medications have not been shown to be very effective. So there are trials where there are negative trials are both sertraline, mirtazapine. It has not been found to be very effective. But ECT, there are is definitely one of the possibilities. Even swallowing medication was a challenge for him. He would simply hold the food and then he would. It was almost like a keratonia, and that even in a person with dementia, he actually saying the names of children, recognizing the wife, making some simple communications, some improvement in identifying toilet needs. All those things were a very meaningful improvement, which actually persisted for few months. And now, because of relapse, again, we had to again give another trial of ECTs now, and he's still improving with those aspects. So, yeah, I think one of the benefits of genetic diagnosis was giving a relief to the family, in the sense that it is autosomal recessive, and that way the risk for the next generation is quite less, because it's such a rare condition where both the parents have to be carriers. And then unfortunately in this generation, almost all the children have only one person who is kind of still not having full symptoms, but still he has he's very apprehensive about developing the condition. So, and he was not very amenable for evaluation also. And there's some behavioral change already there is there to some extent. So we might have to evaluate in future. I think for want of time, I think we will go on to the next case. And I think the lot of questions from the chat box, we can take it together in the end. Some of the things I think our team will kind of pull in the questions, and whatever the relevant questions for all the cases, we'll take it up in the end.
Now I request Dr. Nandini, working as senior resident in Geriatric Psychiatric Unit, for a next case presentation.
Good evening all. I'm Dr. Nandini Bojappan, working as a senior resident in Geriatric Unit and Department of Psychiatry in NIMHANS. So bipolar depression itself has its own hiccups when it comes to treatment, even in adult population. So here I'll be discussing a case wherein an elderly gentleman presents with bipolar depression with multiple comorbidities. How it goes on, he has multiple factors which could worsen the illness itself and prone for side effects with the medication which we generally use for bipolar depression. I'd be covering all of it in my small summary. So he is Mr. X, 80 years old male with well-adjusted premorbid personality. He was on regular medication for type 2 diabetes mellitus and hypertension for 25 years. He also had concurrent ischemic heart disease for past 5 years and was also medication for the same. He presents with illness of insidious onset, episodic course of 8 years duration. So coming to the past illness, so first episode of depression was in 2016. He had presented with pervasive persistent low mood, anhedonia, fatigue, sleep and appetite disturbances, depressive cognitions, and death wishes. And he had improved with desvenlafaxine 150 mg. So after discharge, within 3 months, he had relapsed while he was on medication. Hence, he had the second admission in 2017. And then he was diagnosed with severe depression without psychotic symptoms. He was started on sertraline, increased up to 200 milligram, was also given concurrent ECTs. Patient had complete improvement with the same and was maintaining well for next 2 years. And while on sertraline, patient has had a switch. He had switched to hypomania in 2020. This episode of hypomania was treated with valproate and aripiprazole. A patient had responded to it. And after a year, during follow-up, we had found out that patient had developed hyperammonemia. Hence, valproate had to be tapered and stopped. And then after that, patient had developed a hypomania episode in 2021, for which quetiapine was initially started. And patient had excess daytime sedation with the same, hence further dose escalation was not possible. So in the background of the same, current admission, current episode was insidious in onset for around 2 to 3 months, characterized by loss of interest, increased somatic concerns, difficulty in initiating and maintaining sleep, reduced appetite, anhedonia, fatigue, leading to socio-occupational decline. So mental status examination wise, just summarizing it, there was reduced psychomotor activity, speech, tone, tempo, volume was reduced, and thought wise he had increased somatic concerns. Mood, he had dysphoric affect, range restricted, reactivity was reduced. Perception, we were not able to detect any abnormality, and insight was present. So course in hospital. So when you look at the past history, what we had found is that patient initially responded to desvenlafaxine, then there was a breakthrough with the same. Mirtazapine, there was no response. Escitalopram, there was no response. And sertraline, earlier there was a response, and later he had a switch. On the background of the same, patient got admitted. So when patient got admitted, even before patient getting in, we had started the patient on cariprazine for bipolar depression. So from 1.5 mg to we had increased it up to 3 mg. So after admission, we had noticed that patient had perioral movements, he had lingual tremors. Hence, after around 2 weeks, we had tapered and stopped cariprazine. Concurrently, during that 2 weeks time, we had also initiated RTMS. So we had what we had found is that there was worsening despite starting patient on RTMS, and we had to initiate ECT. So with ECT, there was improvement in his depressive symptoms. And what we had planned is that we thought we would maintain the patient on lithium and vortioxetine combination. So what we had noticed is that cariprazine was stopped by the end of February. So after around 4 to 5 weeks after the same, when patient was on lithium vortioxetine combination, which we had initiated around 1 week before the onset of the side effects. The side effects here, what I'm trying to mention is that patient started reporting of subjective restlessness, which I've indicated with the arrows. So I'll just brush through this key. This inverted arrow is akathisia, which I have mentioned here. And this round here mentioned depressive symptoms. And this one, the yellow one, here indicates the RBD. So which I would be coming later. So initially, with ECT, there was improvement in depressive symptoms. And after that, we had noticed that patient had started reporting of subjective restlessness. And we also observed objective restlessness while examining the patient. Hence, we are worried about the side effects and which caused significant dysfunction. Hence, what we had, when we had temporally correlated with the drugs, we had found that most likely it would be secondary to cariprazine. Cariprazine is a drug which would take around 4 to 6 weeks for it to show its effect and also its side effects. So possibly cariprazine, which was increased around 5 weeks before the onset of these side effects and also stopped around 4 weeks before the onset of side effects, possibly would have led to these side effects is what we had concurred. And there is also a possibility of it being further worsened by the vortioxetine. And hence, we had stopped cariprazine. We had also started medication for his akathisia. We had started him on propranolol, and we had increased the dose based on the tolerability. So with that, what we had noticed is if you look at these arrows, you'll find that over time, the restlessness actually came down, but the depressive symptoms increased because we had stopped ECT, we had stopped him all the medication which would handle his mood. So with time, as his depressive symptoms increased, we had restarted the patient on ECT. And with ECT, there was improvement in his depressive symptoms. We had started patient on duloxetine. We had started around 10 and increased up to 40 milligram. We had also started on lithium. So what had happened is that during this phase, with duloxetine, patient had started developing REM behavioral disorder. So hence, duloxetine has to be reduced. So improvement-wise, with ECT, there was improvement in his somatic symptoms, in his mood, in his sleep, in his appetite, in his fatigue. But still, patient still had some anhedonia. Patient had subjective low mood versus complaints. So we tried psychological interventions in between. But patient was not very cooperative for the same. He was quite authoritative and he was resisting any other intervention except for pharmacological or non-invasive brain stimulation. Hence, we are not very successful in psychological intervention for now. When the patient was discharged, patient was put on lithium, and he was discharged with the same. And the plan was to titrate up lithium based on the lithium levels, and to long-term plan was, number one was to maintain the patient on lithium, and number two, also to consider psychological interventions, because most of the episodes, which were depressive episodes in particular, were secondary to life stressors. So hence, patient would benefit from psychological intervention. So the plan was to over time to engage patient in psychological intervention so that further episodes aren't precipitated. And this is the overall view of this patient's course in hospital. Yeah, so I'm just have summarized all these side effects with medications. You had one or the other side effect with almost all the medications which are generally used for bipolar depression. And while now coming to the salient feature, number one is that he had non-response to multiple agents. Number two is he had intolerance to standard drugs for bipolar depression. And when we tried to attempt psychological interventions, patient was very resistant. He was not, secondly to his understanding of psychiatry, he was not very in for psychological intervention proposed by the treating team. And as patient had multiple comorbidities, we had to handle the medications based on his side effect profile, his other medications. And for during admission, he was on non-opioid analgesics. He was on medications that were serotonin agonist, which these medication in turn have effect possibility of them leading to akathisia. So we had to sit and work on the multiple medication which could lead to these side effects and had to taper and stop them. And there are a lot of interaction possible between these medication and the patients, the medication which we started on. And in between, we had also started patient on Ayurveda medications for his constipation and for his gastritis. Hence, at a point there was possibility of a lot of interaction between these medications, and hence this was considered as a challenge while treating this patient. Thank you.
Thank you, Dr. Nandini. So we saw that this patient basically had a lot of challenges with respect to pharmacological management. Also with the psychological management, but I'll come to that later. So I just wanted to know what are the current plan and what are the challenges with respect to pharmacological management way ahead now that he has not responded.
So plan as such would be, now patient is on lithium. So we would increase lithium, and based on his lithium levels, we prefer maintaining him on lithium. That's the plan number one. And along with it, number two would be starting him on therapy so that he doesn't go for another episode when he has some psychosocial stressor. And number three would also be concurrently with the lithium. Next would be the psychological intervention. Number three is also psychoeducation of family. We felt there was significant burnout in wife. She was not able to handle patients, recurrent episodes and patients, some somatic symptoms. Hence, psychoeducation and building up a support system is also part of the plan. If lithium doesn't work, plan B would be putting patient on maintenance ECT. And along with psychosocial interventions and also intervention from PSW side. This is a plan which we have made as of now. Based on patient response, we would also try other medications if required.
Thank you, Dr. Nandini. I request Dr. Matthew sir to provide his comment on what is the role of psychological intervention in a patient profile like this, especially since Nandini was mentioning issues like being authoritative, resisting to the therapy.
If you don't mind, I'll ask questions. So, question for you is he right now, is the patient remitted or not? Is he euthymic? And this episode, when he came in, you said he came in with depression. Did he switch to mania in this episode also? And the third question is, how many ECTs did he get? Did the depression remit fully with ECTs?
Patient did not remit fully with ECTs, sir. Even now, he has got anhedonia.
How many ECTs did he get?
Patient had received 7 ECTs.
Okay. Right, then?
And he still has anhedonia, subjective low mood, and at times has somatic complaints too. And second question is,
did he switch to mania?
So this episode, he had come with a hypomania.
We come with hypomania.
Yeah, initially in
depression.
September 2021, he had come with a hypomania. Then after that, for hypomania, we had started him on quetiapine. And over time, he had gone to a depressive episode. For that, we had started him on cariprazine.
Yeah, but the admission was for depression.
Yes, sir.
He was admitted for depression.
Yes,
So
sir.
it was bipolar depression.
Yes.
And the mania was hypomania or mania?
It was hypomania.
So it's a bipolar 2.
Yes, sir.
Okay. And so right now he's in remission?
Yes.
Euthymic.
He's euthymic, but he still has some residual symptoms.
What, like what?
Sir, he at times reports of sleep disturbances, somatic complaints, and fatigue is still present.
And right now it's only on lithium.
Yes, sir.
Okay. And duloxetine.
Yeah.
So first of all, my comment on this. Number one, we are dealing with a person with bipolar depression. So in bipolar depression, if you go by any of the guidelines, either the International Bipolar Disorder Society or the CANMAT or any of the other guidelines, the standard treatment of bipolar depression should be with mood stabilizers. Whether it's, I think you used valproate earlier on, but now you're on lithium.
Yes.
Both are, valproate is stopped, isn't it?
He had hyperammonemia with valproate,
Yeah,
hence
okay.
it was
So-
stopped.
So lithium is, I guess, a very good drug to give, even though the person is 80 plus. There's no contraindication to giving lithium to this person. The only thing that you have to watch out is the interaction that it might have with other drugs that he's on for maybe hypertension and stuff like that, because, it's an issue giving lithium with ACE inhibitors and other kind of, ARBs and so on, because of the problem with the electrolytes. Lithium is definitely the treatment. And with lithium, it's also, if the person faces depression, it is easier to give ECTs rather than having the person on valproate or some of the other, drugs for epilepsy. My opinion, my way of managing would have been to give him more ECTs, because if you look at the series that we have from the geriatric clinic, the number of ECTs that the person needs to get for psychotic depression or for any bipolar depression is more than 8. So in fact, if you look at the whole series that we have, the number of ECTs that we've given is anything from 10 to 15. On an average of about 12 is what is there in the series. So I would have gone on to give ECTs, continued ECTs, unless there is a problem. If there's a problem of cognitive disturbance, I would have spaced out the ECTs and maybe given them one ECT every maybe 2 ECTs a week or 1 ECT a week or so. That's what I would have done. If the person is remitted, I would just continue only with lithium, because lithium is for maintaining prophylaxis. Lithium is a good enough drug. If the person has got some mild depressive symptoms, I wouldn't really worry so much about it, because at this age, you might expect some residual symptoms. So I think I would just continue with only lithium and maintain a proper lithium level of at least anything from 0.6 to 0.8, so that the person has, it does not, you hope that he does not relapse. The fact that he relapsed every time with psychosocial stressors definitely is a pointer to do therapy. I don't know what the stressors are, so I wouldn't run and do just CBT. It might be anything from CBT to family therapy to supportive therapy, whatever it is that the stressor caused. I would think that at this age, it might be difficult to do CBT at 80. Not that it's not done, but I suspect there might be other issues in the family which might have caused the relapse. So I would rather explore the family situation, or the, I don't know if it's married, if he's got a wife or other people, but I would explore that area. And definitely therapy is something that either supportive CBT or family therapy, some point of therapy is definitely something that should be done, because if you have the history that is relapsed every time with the psychosocial stressor, that is definitely something that you need to look at.
Sir, just a small correction. So initially he had received around 10 to 12 ECTs. Then we had stopped it. And after that, again, there was worsening after stopping medications. Hence, we had restarted and given 7 ECTs. Plan was to stop duloxetine and only maintain the patient on lithium, sir.
Yeah, I think we are also kind of keeping the plan open for giving some kind of tapering ECTs, maintenance ECTs if required. So already had the whole number of ECTs was 17. So he's actually had, and there are some cognitive issues also was there. I think one of the issues in this patient is the wife who was a caregiver, primary caregiver.
I know it's exciting to try vortioxetine and all the other new drugs, cariprazine and everything else. It's okay to try it and see whether it works. But if you look at the evidence is not much stronger than the standard treatment guidelines, and that is the SSRIs or the tricyclics. So the standard treatment guidelines is really what you should go by. I know Shivkumar will want to respond about this, but the new medicines, whether it's cariprazine or vortioxetine or any of the other new medicines, either for mania or for bipolar or for depression, is something that you really reserve for rare cases. It's okay to prescribe it and see how it works and get an experience. Our experience with lorazepam is quite bad. So now actually we are all very excited and we gave everybody lorazepam in those days. But then I think nobody gets lorazepam now, isn't it? Hardly given. So these will be.
I think if you looked at the profile of medications, what this person has been tried, he has been tried on multiple drugs. Already multiple SSRIs have been tried. And he had a lot of somatic complaints. He was on multiple analgesics, including tricyclics. And he had constipation was a big issue for him. And with a low dose of tricyclics itself, he had to get a high drugs for treating constipation. He had a long list of medications. So tricyclics was out of question for us because of cardiac issues as well as for constipation. So that's why actually ECT, the previous episode also, ECT was the only thing which he responded very well and subsequently maintained on sertraline. And I couldn't try tricyclics because of adverse effects considerations. And I think vortioxetine, we have tried in quite a few patients with elderly. And so far, the tolerability wise and the response wise, there has been reasonably fine. It's not a wonder drug that they will not develop any side effects. There are people who developed hyponatremia. I think one patient recently we had. So any drug is not going to be completely safe in elderly. So so far the literature, what is available for vortioxetine, there has been some benefits in terms of lesser side effects compared to other drugs. TCAs, nortriptyline is something which is recommended, but any TCAs in 80 plus is going to be a challenge. He also had some cognitive issues even with ECTs. So it's quite challenging. With respect to therapy, I think we did do a lot of things with the family, with the caregiver. The wife was also having depression. He was a person who was very authoritative as a premorbid personality. It is not as a part of mania or a part of the symptoms. So he would demand a lot of attention from the from the caregiver, both the family caregiver as well as the children. Both the children were very supportive and cordial, but still they had to kind of yield to all his demands. And the paid caregivers were not able to take care of him. They had to change multiple people. So all those things were there. And to give a respite for the wife, that was a big difficulty because she was already taking mirtazapine and she was not able to sleep. So those things were the issues. Psychotherapy, his attitude was expecting a very quick fix relief. You make me better in terms of restlessness. You improve with medications. I will not do any activity. I will not step out of the hospital. So that was the challenge. And he would not listen to the therapist that easily. So I think that is, and also age of the therapist. I think that was one of the concerns. He was treating as a small, he would kind of listen to the consultants to some extent, but when the residents goes, he would boss over. So I don't know. I think that is something like with respect to geriatric therapy. How does the age of the therapist and the patient who is kind of elderly? I would like to ask Dr. Matthew, is there a kind of approach what you try? And a lot of people who are from the psychology and nursing background, I think it'll be very helpful if you can comment on that.
So I think therapy with younger therapists is what you're saying. Therapy with younger therapists is not something that is not doable. In the psychotherapy group, I always quote a case where I saw a gentleman who was 60 plus, who had his spouse died, and then I was I think 18 or 20-year-old resident doing therapy, and then the challenges that I face. But I think if you are a competent therapist and you're confident, and you if you don't tell an elderly person what to do, I think therapy would work very well, because after all, an elderly person who's 60 or 70 has a wealth of experience compared to somebody who's in their 20s or 30s. So obviously you have to do a lot of listening, do a lot of support, tell the person that a lot of the answers are coming from him rather than you're going to provide any answers. And you have to really use what is called as the one-down approach to get the patient to respond and feel that he can feel much better. But I think the challenge actually with a person like this would be to do CBT, because he will not follow any things that you tell him to do. So in the older age group, CBT is not something that research has shown is very doable, because many of the elderly people don't want to do any of these homework assignments and exercises, and the motivation to do therapy might be much lower there. But supportive therapy, a lot of supportive techniques, emotional kind of therapies, these are quite doable in the older age group. So you have to make some changes, but I think therapy is not something that is not doable.
Thank you, sir. I would now request Dr. Aarti, a DM resident working as senior resident in Geriatric Psychiatric Unit, for the next case discussion.
Good evening. I'm Dr. Aarti, second year senior resident in Geriatric Clinic. So I'll be presenting a case vignette based on the topic medical comorbidity contributing to cognitive impairment. So this patient is one person we consider, the case management is one we consider as an apt example, which highlights the importance of comprehensive assessment as well as comprehensive management of the conditions in an elderly, like the primary psychiatric or neurocognitive diagnosis, the psychosocial aspects, and also the medical comorbidities. So my patient is a 71-year-old lady, 10th standard educated housewife from a very affluent background from Tamil Nadu. And she was brought to her screening OPD for the first time by her cousin's grandson and cousin. And she had long-standing history of diabetes, hypertension for around 25 years of duration, for which she was on medications, and she had grade 2 obesity. So she had a past history of depressive episode of mild to moderate severity at around 53 years of age, which lasted for around 3 months, and she was treated, subsequent to which it resolved, and we do not have any treatment records on that. And there is family history of depression in one of her cousins. So when the patient had presented, she had a total duration of symptoms of around 8 months duration, which was precipitated by a stressor of subacute onset and which was gradually progressive. So initially symptoms began with worries related to the stressor and decreased sleep, which was initial insomnia. And within around 1 month, it progressed to pervasive low mood, decreased interest, anhedonia, decreased energy. And premorbidly, she was a very active person, very authoritative, managing multiple servants and multiple activities in the household, pursuing her interest. So she stopped having interest in all these activities and limited herself to her room. And there were episodes of vague fears and reassurance seeking behavior, along with pessimistic thoughts, decreased self-esteem, decreased appetite, occasional death wishes, worsening sleep and appetite as the disease progressed, with significant biopsychosocial dysfunction. And the additional concerns that this patient had was there was a key event or around 6 weeks into the after the onset of the symptoms, while she was on the paroxetine, amisulpride, and lorazepam, she had a history of fall in the bathroom, which led to a significant worsening of her symptoms. There were multiple contributory factors for that. Like one was that they had defaulted the medications and given priority to that incident or medical condition. And so there was one worsening. And associated with the worsening of her symptoms, patient did not want to get up from bed. She was afraid of falling again. And then another thing was the attitude of the family. Even though they meant well, having poor understanding about the condition, about depression, they actually went along with the demands of the patient. And in order to care for her, they decided to give everything in bed, to the extent that even the bowel and bladder evacuation, they were allowing her to do in the bed. And she was put on diaper throughout day and night, while only what she had actually was a hip sprain, for which the orthopedician had advised short-term analgesics and advised few days of bed rest. So this continued 2 months of bed rest and decreased mobility with subsequent difficulty in initiating walking again. So that was one additional concern. And she had history of hyponatremia and delirium, and which had to be treated on outpatient basis, and it was associated with worsening of her depressive symptoms, and subsequently required IP care in a medical setting. And she was found to have uncontrolled hypertension and UTI, and all these were managed. Then there was this concern of over-the-counter abuse of benzodiazepines. The patient's husband, in order to make it convenient for her, in order to decrease her anxiety, he was giving her alprazolam on and off. And the major challenge one that we identified at this point was, of course, in addition to this, the poor understanding of the family. Husband was an elderly 85-year-old gentleman who was a survivor of cholangiocarcinoma. And he also had difficulty in coping up with the demands that the patient was having. And there were interpersonal issues with her children. That is why we can see that she was brought by her distant relative. So then the treatment, we can see that initially she was treated with paroxetine, amisulpride, and lorazepam into 2 weeks after her onset of symptoms. Only sleep had improved, and with the fall that was stopped. Then she had a trial of fluoxetine for around 3 months along with clonazepam. And there was only, that was after her IP care for hyponatremia. And with that, she had some improvement in her food intake and a little bit of initiative to mobilize. And she had come to our OPD, screening OP in March 2021, when mirtazapine was started for her. And considering her primary complaints of decreased sleep, decreased appetite, and other history of hyponatremia, with the SOS clonazepam, she had around 40 to 50% of improvement with that. Her mood was slightly better. She started interacting a little more, and a few times she used to walk to washroom for self-care activities. But subsequent to that, after around 1 month, these symptoms worsened, and she again came to us. She was initiated on vortioxetine and melatonin, and IP care was advised, considering or the multi-dimensional approach which was needed. So initially our working diagnosis was only recurrent depressive disorder, current episode severe with psychotic symptoms, and IP care was done for further diagnostic clarification, management of depression, and also primarily psychosocial intervention. Then in the first IP care, when we did the detailed evaluation and diagnostic clarification, we collected history from multiple informants, and we even though it was not a very clear picture, we did get some history from her husband that the gait impairments had been present even prior to the onset of the depressive symptoms, maybe few months from his memory. And her daughter, who was in US and visiting only occasionally, remembers that when she had come 2.5 years before the onset of these symptoms, a patient was found to have a habit of unnecessarily purchasing saris excessively, easy irritability, some insensitive comments, and use of some abusive words which she didn't use before. But much of corroborative history we could not get from husband, but considering these symptoms, and along with this other symptoms, we had considered a frontal behavioral this to be part of the frontal behavioral symptoms. And physical examination, she was a very uncooperative patient, and similar to the previous patient, was very authoritative by nature and outright would tell that she doesn't want to cooperate. So we got the findings of spontaneous retropulsion, minimal symmetrical cogwheel rigidity. She had axial rigidity, hypomimia, bradykinesia, and some cerebellar signs on left side, for which we had licensed with the neurologist team, and they gave a diagnosis of probable PSP behavioral variant FTD with vascular overlap, also based on the small vessel ischemic changes in an MRI. And they had suggested starting Seligelin 5 milligram for her and PET MRI. And we attempted a neuropsych assessment, but due to, as the patient was uncooperative, it could not be done in detail, and it was difficult even to get her do HMSE. So that was also done in piecemeal, and it had a score of 28. And fluency was something which was found to be impaired in whatever ACE and neuropsych assessment that was possible. And investigations, apart from the deranged diabetic status, even the extensive workup with autoimmune paraneoplastic, everything turned out to be negative. And PET MRI, first admission we were not able to do as we did not get a date. And we had also licensed with the physiotherapist because she was finding it difficult to, she had fear of falling and she was finding it difficult to walk again. So we had sent her for gait training. Few sessions she cooperated, which was found to be beneficial for her. Then the management of comorbidity was another challenge we had with her: diabetes, hypertension, hyponatremia. And we had licensed with her own family physician, and based on that, we optimized her medications, removed the thiazide, and then optimized her OHA and insulin. And dietitian consultation was also done to optimize the diet while inpatient, which the patient even continued after discharge. So management of depression, since she was showing response to vortioxetine, we had titrated that while this IP up to 10 milligram. And the sleep assessment also was suggestive of some REM behavioral problems, because of which clonazepam and lorazepam was tried. So either it was she wouldn't get adequate sleep, or she would be excessively drowsy the next day, which impaired with her activities. So mirtazapine was also not helping, and melatonin was also not helping. And zolpidem, she had some response, and she used to get around 6 hours of sleep, even though she had some terminal insomnia. Then behavioral, we had also, as one management strategy, we had also attempted to give her TDCS, but as she was uncooperative, she dropped out after 4 sessions. And behavioral interventions were focused, and there was PSW team involvement, and but she was not very cooperative with a lot of people, so we had to restrict our activity to a few people in the treatment team. And we had suggested sleep hygiene measures, and since she used to hold her urine for a long time, and even after getting that urgency, she had this episodes of incontinence, which was managed to some extent with timed voiding strategies. And we had done activity scheduling, for which the patient was not very cooperative, but little by little we were able to incorporate it into her routine. And psychoeducation of the family and the paid caregiver was one of the main things that we had attended, because the family had no idea. She was living with her husband and the paid caregiver, and so they had no idea regarding her primary diagnosis and how to care for her. And we had updated them about the status of her condition and the intervention strategy. So this time when we had discharged her, we had this FTD PSP overlap, which has added on to this diagnosis. And after the discharge, there was, and Seligelin was also given along with these medicines. She had significant improvement in her mood. Motor symptoms markedly improved, which even continues now also. She started walking, and she would even attended some of the activities in the kitchen, went to supervise that. She would do, she interacted, started smiling. So with that, her sleep was also better, but that was only for the initial 1 month. After that, she had again, she had worsening of the sleep, which was again causing her to have excessive anxiety. And Second time we had to admit her with a new set of symptoms on top of that, and it was she started developing some sexually disinhibited behaviors and excessive clinginess to caregiver and fear to be alone. So with this, when we had admitted her, we had considered the possibility of any drug inducing this problem. And Seligilin is, even though it is not a very common drug that which can cause this, there are case reports on that. So we discussed with the neuro team, and we decided stopping Seligilin, with which the symptom was found to resolve. And then management of depressive symptoms, again vortioxetine we titrated, and to as an augmentation strategy, RTMS was also given. And sleep, that time we had attempted trazodone, with which she was not having adequate benefit. That is when we suspected, we did a specific detailed history for the sleep, and we suspected the possibility of obstructive sleep apnea, considering her profile of obesity, the history of snoring and daytime somnolence that we were able to get. And we did a sleep study which showed severe obstructive sleep apnea with a desaturation of around 77%. Her apnea hypopnea index was 42.3. So we know it is between 5 to 15, 15 to 30, and above 30, we consider it as severe. So she had severe sleep apnea. So in liaison with the pulmonologist, we did a CPAP titration study and initiated her on CPAP while inpatient, because she was, it had to be gradually introduced into her routine because she was resisting it very much. And activity scheduling was focused more this time, and so under supervision she was made to do small activities which she can continue even after discharge with positive reinforcement. And the caregiver burden, especially this time, what we could find was that there was a lot of burnout in the primary caregiver, who was actually the paid nurse who was taking care of the patient. So she had, in addition to the physical and emotional strain for caring for this patient, who was very demanding even premorbidly. And she also had this problem with her sexually disinhibited behavior. So that was a lot of concern to her, and with her own personal stresses, she was finding it very difficult to cope with the situation. So that was one area where we had provided the intervention. So as I, most of the things I have covered in my this discussion itself, we had many challenges in assessment as well as diagnosis with this consideration of depression as well as the behavioral variant FTD. And then management of depression was another concern, as well as the management of medical comorbidity. So currently the patient continues to use the CPAP, and sleep has improved markedly, and she was maintaining well. But the recent update is that we are again having some, in the last 1 week, there seems to be some psychosocial issues, and one more episode of UTI that we are treating her now. So this was the outcome of the treatment of this patient. I think we can discuss.
Thank you, Dr. Aarti. So one thing you was mentioning about is requirement of a paid caregiver for a very long time in this patient. So can you talk more about what were the major difficulties with respect to that nursing care?
So here one of the problem was something that we see usually, because elderly patient means usually the primary caregiver will be the spouse, who is also elderly with their own set of medical comorbidity, and there may be other interpersonal issues, marital issues. So in this case also, the one thing was that husband, he was survivor of cholangiocarcinoma. Physically, he was not able to take care of this patient. We can see that she was bedridden. So from the initial time itself, they have appointed one caregiver, actually two people who used to take turns and come. But one of this, she was a trained nurse, and she was mostly there with the patient from the beginning. So almost for more than 1 year, she only is taking care of the patient. So one thing that she had difficulty in managing was one thing about the personality profile of the patient. They were too much demanding, and the family also, since their attitude was also like, since they were paying her, she's supposed to do all the activities, even toileting. So she was finding it little difficult because she had to do it on a day-to-day basis. And the second thing was, it was physically exhausting for her. She was an obese lady. So to take care of her was one physical challenge for her. And the third thing was that she was, after psychoeducation, she was reasonably doing well, and she was a good informant also. Many information of inpatient care we had actually got from her. And the one thing that she found difficult was when the patient developed sexually disinhibited behavior. So she would make some comments, and some groping behavior was there. So the nurse was finding it very difficult to handle. So these were the major challenges. And one thing was that most of the behavioral measures that we discussed with her, she was trying to put it into practice, like positive reinforcement and making the patient mobilize, doing small activities. But again, there were some problems, like from the family, that they wanted the patient to be comfortable and they were paying her. So there was something like she had to do that, and she should not pressurize the patient. So that was handled in the second IP care. We had spoken to her family, and to some extent we were able to deal with that.
Thank you. I now request Dr. Matthew sir to comment upon the diagnostics challenges in such patient where FTD was kept as diagnosis and depression also was considered. Sir, diagnostic challenges in dementia versus depression.
Diagnostic dementia versus depression.
FTD versus.
I don't know, because depression is something very different from FTD. Now, what can make you suspect FTD when you have depression is the apathy and the lack of concern. But that shouldn't, for a psychiatrist, that should not be difficult at all, because psychiatrists are very used to diagnosing depression. But I find that many neurologists might make a mistake, in the sense that they might mistake apathy for depression. And many of the symptoms that the person has, if the person has got depression, might mimic FTD. So I don't think there's a challenge between diagnosing depression and FTD. But remember that geriatric depression is something that can be a forerunner of dementia. Very commonly Alzheimer's disease, but also FTD. So if a person has got depression and you are finding it difficult to treat, you're, like in the case of the earlier person who had bipolar, even that person might turn out to have a dementia as the time goes on. Hello. Yeah, so I think the challenge is indeed, as you've seen it with many other cases, is to treat the depression. Treating geriatric depression is a big challenge because it's very difficult to treat. It's chronic. There are many relapses. The response is not 100%. You will never, many of the times you will not achieve full remission. So those are the real challenges, because even now there are cases that I've seen where they're struggling with many years of depression, 2 or 3 years or 5 years of depression, and then suddenly the depression goes away, and you wonder what you did. You didn't do anything; it just went away. So I don't think FTD and depression is a challenge. FTD and the other dementias is always a challenge, because with very well with Alzheimer's also in the first initial period, you can get a picture of apathy, lack of interest, behavioral symptoms. So many times you might mistake an FTD for an AD. or a psychotic illness for an FTD. So I don't think there's a difficulty with FTD and depression really. I've not found that as a, was that your question, or did you want anything better than that?
I think one of the issues is that when people who present with predominantly apathy, vascular depression, people can have apathy, and when they have treatment resistance in chronic depression, I think that is something, one of the differentials we need to keep. I think we may be treating as depression. Often the neurodegenerative disorder actually can start in this patient, the functional decline, and some of the history we may miss some of the behavioral changes, like because there may not be good informants who would have closely observed and then told about personality changes. So, so one needs, and FTD is also a condition where you may not have the memory complaint as a primary thing. So it can, this is one of the differential one has to keep. If depression is not responding, you are trying multiple interventions, and then the person's functional decline is happening, and there are personality changes which is emerging. So you need to be sensitive into kind of pick it up and then first subsequently evaluate. So that is one of the, I think there is one recent article in Brain which I've discussed about overlap of depression and bipolar disorder, behavioral variant of FTD and bipolar disorder, as well as with depression, as to how the consensus criteria, because there's no classical kind of biomarker which is available. It is more of a clinical diagnosis, and many times the FTD also may not have a very clear structural kind of focal changes. So these is PET MRI actually gives some kind of advantage where you can actually pick up an early kind of changes where there's regional hypometabolism is there, and that can actually be more sensitive than MRI, which many times if you do MRI, you may have a more of a diffuse atrophy, or you may not actually find a significant focal involvement. So the main advantage of picking up this is prognostication will be different. And if you pick up that, you may have a person who has some element of depression, some element of cognitive decline, where the family needs to be educated properly, and then the care, supportive care has to be provided also as well. So that should not prevent us from treating depression adequately. At the same time, we should not kind of end up doing things like without being sensitive about an evolving cognitive decline. So that is the point what we were trying to make.
Yeah. So I think for me as a psychiatrist, I always say that FTD is my last diagnosis. I would try to rule out all other diagnoses before I diagnose FTD, because for me, FTD is those specific conditions which are referred to as degenerative frontotemporal dementia. Many things mimic FTD. The articles that you refer to in Brain and others, I've seen those articles, and they are those talk about the challenges of diagnosing depression, and they're all written by neurologists. They're not written by psychiatrists. For neurologists, it's a challenge because neurologists don't see depression every day. We see depression every day. We see psychosis every day. We see all kinds of other behavioral problems every day. So for me, FTD is something that I would diagnose last. Again, about my own impression about PET scan, unless you have an amyloid scan, which can be diagnostic, I would believe that the scan that we have now is basically an FDG PET. An FDG PET is a very dirty scan, which is very non-specific. You can get hypometabolism in different parts of the brain, which can be absolutely non-specific. So I've always maintained, and I'm still looking for a paper which will tell you that you can distinguish FTD or dementia from depression. If anybody can show me a paper like that, I'll be happy to look at it.
It's more as a corroborative evidence.
Yeah,
it's not diagnosis is not based on only imaging.
FTG PET is dirty.
The only I don't agree with that. The only advantage of because a lot of times the scan means only CT or MRI, where it may not be sensitive to pick up regional kind of changes. So the only advantage where the PET has been approved is actually to distinguish behavioral variant FTD or FTD, primarily because the subregional or the regional changes can be picked up. If you have a very clear knife blade atrophy in a focal and temporal, in a frontal and temporal area, MRI can be this thing. How many such MRIs actually we can actually see? So that is something like most of the times it will be diffuse atrophy. So it will not be sensitive, particularly in the early stages. So that is where the advantage is. I think we can have discussions on that, but I think there are some, we are already running out of time. So there are questions which have come in the participants, and somebody has raised a hand. Maybe can we allow them to ask? And there are some chat questions which has come. I would address that. I think one of the question is that about I think about the first case what Thomas had presented. So why didn't you consider Huntington's as a possibility? So can you answer that, Thomas?
Yeah, that's a very important question, because Huntington's disease often has a kind of similar phenotype. But the thing is that it should also start with some movement disorder, should have some chorea or choreathertotic kind of phenomena. And subsequently, it should be autosomally dominantly inherited. So here that Huntington gene, that autosomal dominant inheritance was not evident. And psychosis and psychiatric disorders as well as cognitive part actually develops after development of the movement disorder. So these are some of the clues which is against Huntington. But however, we have to still rule out a possibility of Huntington's in a person who comes at young onset with familial kind of dementia. So this would be my approach. And I think that will also request further inputs from both Matthew sir and Shivakumar sir, especially because NIMHANS has an experience and as a cohort of patients, registry of patients who have Huntington's disease.
Yeah, I think in this patient, it was primarily because both the parents were asymptomatic. And that's why we didn't think of autosomal dominant kind of pathology. And when we tested this, if it had come as negative, probably we would have gone ahead and tested other possibilities also. Since we could get a positive testing because the whole exome sequencing was done, I think that's where we didn't go on to test further. So as Dr. Matthew had told, storage disorders was one of the possibilities. So we were going, I think this whole exome sequencing would test for several genes, and that it clinches the diagnosis and the clinical presentation and the pattern of only the current generation being involved. It matched with the recessive type, very rare condition. So that cleans the diagnosis. Thanks, Thomas, for this.
So I think Huntington's is definitely one of the considerations, because I can still sporadic Huntington's, you may not actually get anybody in the family. I specifically remember a patient that I saw who was 45, who had all the features of FTD. And that is one of the cases I made a diagnosis of FTD, because everything, it was seen everywhere. It was seen in CMC Vellore neurology, it was seen in NIMHANS, it was seen in, I think, some other hospital in Bangalore by various neurologists and psychiatrists. And various people have made a diagnosis of either FTD or AD. Because by the time it came to us, the FTD symptoms had gone and she had a lot of cognitive symptoms. So we treated her with the standard treatment for that. About 5 to 8 years later, the patient was quite, incapacitated and, not able to speak and all that, and in bed. But the son complained of some flinging movements. We never thought of Huntington's at that point in time, because purely for the same reason that you're saying, there's no family history, nobody else said. Then when we took the history later on, we found that an older brother had some tremor, not typically Huntington's choreoathetosis, but some tremor, and he had died, but much later age. He was in his 70s or 80s when he died. But this lady was 40, 45 when she came to us. So then when we saw her, because she was bedbound, then we called her and saw her, and we found that she had quite typical choreoathetotic movements. But by then she had also been on some antipsychotics and all that, because of, she had some behavioral symptoms, and that was required. Then we suspected HD, then sent for testing, and then it came positive. And then of course, a few years later, she died. So nothing is as typical as you can.
Because
I can remember cases like this.
Diagnosis, so we didn't pursue further. So can we ask
the other diagnosis, of course, you should think of is CJD.
Yeah.
If it is very rapid, especially when you have one generation with many people, then you should think of CJD. Because that is
here, people had very chronic things, 6 years, multiple years.
It's not rapid. If you think of rapid onset, then you should think of CJD.
Yeah, Mr. Prabhu Arugam, can you unmute and ask your question? Prabhu Armugam? Yeah. So can you unmute? Gina, can you kind of enable? I think it says talking permitted. There is a problem in connectivity. He has raised his hand. Okay, there is one more question about ECT and memory deficits. So I think how ECT is affecting memory, and maybe in the context of people who are having. Yeah, Prabhu, yeah, would you like to ask your question? Maybe we'll go on to the next question after your question.
Will you cognitively adapt the geriatric patient in doing a certain functional activity?
Can you repeat? Can you repeat the question? It was not clear.
How do you cognitively adapt the patients to do their functional activities in the day-to-day activities?
Okay, how do you train elderly to
Yes.
do functional activities?
Yes.
Okay. I would request Dr. Matthew to basically about functional abilities, daily activities in people with mental health issues. You are asking about cognitive disorders or dementia? Cognitive disorders. How do you address the functional activities deficits?
I didn't understand your question very well, because people who have dementia shouldn't in the initial stage have disabilities, no functional disabilities. They should be able to do their ADLs. They are not able to do the ADLs when it comes to latter part of moderate and severe stage. So at that point of time, they will need full assistance. At that point of time, you cannot really do anything to get them to, they'll need full assistance. But in the moderate stage, you can use a lot of behavioral strategies like prompting and mirroring and things like that, and getting them to do as much as they can. So it's definitely a challenge, but if they can have a bath, if somebody stands there and tells them, pour water now, put the soap now, pour water again, wash your soap off, and so on, they stand there and actually do prompting, or somebody shows them what to do, then that is very helpful in things like hygiene, bathing, shaving, and so on. But it's definitely a challenge in the severe stage. Severe stage, it's invariably somebody has to do it for them. I don't know whether that answers your question.
Yeah, I think maybe just a add on, sir. In the initial stages, as sir said, mild dementias, you expect more challenges in the complex activities. Only the things like cooking or things like maybe navigating independently outside, those things will be affected. But the basic ADL like toilet needs or physical mobility, those things will be much preserved. But I think what is important is the caregiver to understand so that they don't understimulate the person and then do everything by themselves. So I think maintaining the cognitive stimulation and whatever level of support is required, that support has to be given. So you should not overdo. And if you do understimulation, again, the worsening can actually be faster. So giving a meaningful quality of life depends on providing the environmental support, which is primarily dependent on the caregiver, as well as the safe environment what is available, which is very, very challenging in many of our home contexts. So for people to kind of keep doing the activities what they have. So that's why there are in developed countries, they're coming up with concepts like dementia village or a dementia friendly community where people will be able to do the activities accounting for the disability what they have with respect to the cognitive impairment. And cognitive stimulation therapies, individual as well as group therapies are being done, as well as I think even in India there are experiences from daycare centers where I think to maintain the functioning, I think daycare is something which is prior to COVID, even in Bangalore, there are several daycares which is operational, and COVID has taken that there's a big hit on daycare. But again, now things are starting to develop, again, restart. And in the initial stages, if somebody is in the mild cognitive impairment or in a mild dementia, daycare can be a very, very useful strategy where people can be engaged in activities in a productive manner. So that is something it's very expensive and cost intensive because the travel and logistics, it's not something very viable kind of solution for many of the organizations to run daycare alone. So that is where it is not expanded in a significant manner. but community-based services, where daycare services for dementia, active aging centers, these are something which can be very helpful. Hope that answered your question, Prabhu.
Thank you.
Right. Thanks for the question. I think there's one more question about ECT and memory. So ECT, when you talk of ECT in any age, memory is one of the main concern. Amnesia, they do have recent memory or retrograde amnesia they develop, and not everybody develops, but there are some significant proportion can have a concern about it. But in our practice, large number of patients actually receive ECTs for severe mental disorders, whether it's a severe depression, whether it is bipolar disorder, or very disruptive schizophrenia. So the benefits are much more than the concern about memory side effects. And in our practice, we monitor every 3 ECTs. There is a separate protocol of assessing recode. There's a battery of tests what we do, and then we monitor. And nowadays there are stimulation protocols. Whether if you, for example, for depression, we try to use right unilateral or bifrontal, which is slightly better compared to the bitemporal which we were using earlier. And the cognitive side effects have not been a major concern in our settings. And even in persons with dementia, ECT per se will not produce a worsening of long-term cognitive deficits. So long-lasting. So generally, it's more of an apprehension than sometimes it can be scary for some persons in a short term. So you need to appropriately educate and monitor closely. If it develops, probably you need to change the stimulation protocol and do spacing out or stop at the right time. And then in our practice, I think ECT is very commonly used because a lot of severe patients with depression comes, and they do very well we don't face a lot of problem. We stop at the right time and then space out. So Sonu Sharma, you wanted to ask a question? Can you unmute and ask? Sonu Sharma? Yeah, I am just looking at, sir. So there are some comments about using non-pharmacological interventions. I think Dr. Mahesh has asked. He's a regular participant even in the VMS program. Most of our effort is to enhance the access to non-pharmacological interventions. It's challenging, particularly for outpatient settings. But tele-psychotherapy sessions, we do a lot now. And even our psychology team has been doing, so that has improved the access. I think in many patients of elderly, as we've seen our presentations, I think either the caregiver intervention or addressing the psychosocial issues, non-pharmacological interventions have a big role, but that needs a lot of resources, and it's a time intensive and human resource intensive. Shonu Sharma, can you unmute and ask? Bina, otherwise, Bina, can you unmute and ask your question? Gina, can you enable them to unmute? I think there are 2 people who have raised their hands. Okay. We'll wait for them to unmute. Or you can, if you're not able to unmute, please, you can type your questions in the chat. There's one more question from Palita. Was there any other intervention given to caregiver, that is paid nurse, other than psychoeducation? Okay, this is related to the case presented by Aarti as to how caregiver support was given primarily to this paid caregiver who was primarily doing it. So other than psychoeducation, what kind of supportive kind of intervention is required for the caregiver? What has been done? I'll ask Dr. Aarti to answer that.
So with regard to this paid attender, one thing was that we had conducted some sessions with her addressing her concerns. And in addition to this problem, she also had some personal stresses. And she was given the opportunity to ventilate, and the supportive sessions were done for her. So in addition to that, we had communicated with the family regarding the need for a respite even for this caregiving person. And while the patient was inpatient itself, they had made for an arrangement like they will take turns during day and night. Two people had come so that she would also get a respite. So initially what they were doing was that both of them would be available during daytime, and at night they would take turns and rest. So some the strategies that can modify it was done, which according to what from our limitations we had communicated with the family members. Third thing was that since she was especially finding it difficult to incorporate this behavioral measures that we were advising her, and she felt that she was not getting the required support from the family, we had psychoeducated the family members regarding that, the need for the diagnosis and the need for the interventions, the relevance of the interventions that she was attempting to do, and that also has uh, given some respite to her. So beyond this, we were not able to involve in any subsequent sessions because of limitations of our resources, but these three things were done.
I think this is a very good question, Palita. I think we see a lot of people now being assisted by professional or paid caregivers. I talked about the training initiative, what we are doing. And when somebody has a mental health problem and dementia, particularly where a lot of paid caregivers are hired, if you this person was very resourceful, and the family was resourceful to appoint a trained nurse. And they were also fortunate to have this person for a long term. And they were very, I think more than a year, this particular paid nurse was in kind of providing a full-time kind of a service for this patient, which is very, very difficult in a person who's getting services from NGOs, from care agencies, where untrained caregivers or not qualified caregivers will be there. Usually these will be people who are 10th standard or they may not have any nursing background. And even for people with nursing background, when it comes to mental health, the level of training is quite limited. So they may not understand the behavioral changes related to dementia. If somebody is abusing, they will take it very personal. So education itself and training and a kind of continuous support is required for them. And the family should be sensitive to their stress. And the family should, many times in our culture, a lot of people, when they hire the caregivers, they don't treat them as professionals. So they treat them as domestic help, so that the respect and their kind of understanding of the challenges, they are also human being. Many times you see the caregiver, paid caregiver, they are 24/7 caregiver. How can a person, if the lot of sleep disturbance is there, that person is not sleeping in the night, and then how can they provide the care in the daytime? So they may not have they are also human beings. So when it comes to caring for elderly, I think there's a lot of challenge in terms of what is affordable for the care, because unlike other countries, we don't have a social care insurance. This caregiving cost is quite phenomenal. It is not easily affordable for a middle class family also. So there are not much of standards and training. So that is where we are actually collaborating with RC, and even the ministry is going to launch a program called as PM Special. That is an initiative to train 1 lakh caregivers. Because there's a great realization that there is a need for paid caregiver training and standardization. So which is going to be mandated in the upcoming amendment of the Maintenance Act also. So I think this is an area, if you look at a lot of global standards, many of the nursing homes in even in developed countries, they face this challenge, because a lot of our nurses actually go and work as paid caregivers in the nursing homes. And even if you look at there also, the nursing ratio and the untrained caregivers who are not qualified nurses is quite problematic, because there may not be many nurses who are available to provide this kind of care. So I think we are running out of time. I think we are almost, we had extended by almost half an hour. So I don't think so. No. I think most of the questions we have addressed. I think some of them who we asked them to unmute, they have not unmuted. Are there anybody who would kind of want to ask last question or anything? If not, I would ask Dr. Thomas to give the vote of thanks. So with that, we'll conclude the program.
It's indeed an honor and privilege to actually propose the vote of thanks in this brief, but actually very wonderful program. And I would like to start by actually proposing vote of thanks to our chairpersons, Dr. Srikala Bharat Madam, who in spite of her busy schedule, and she had actually one of the icons in geriatric psychiatry, she had actually come and she has graced the function online. I thank Madam on behalf of the entire geriatric psychiatry unit here. So that it's a great honor, and we would like to have Madam in person in next programs as well. And special thanks to Matthew sir. Matthew sir has been the beacon for geriatric psychiatry, and he's the one who has founded the geriatric psychiatry unit. And he has been a very strong support to all the residents, the staff, as well as the multidisciplinary team. We very much would like to put in appreciation all our kind of thanks and regards to Matthew sir for coming in person to this program and giving us a lot of enlightenment with respect to managing challenging cases, as well as he also gave a lot of pragmatic kind of advice, which was quite useful. I would also place on record special thanks to the Department of Integrative Medicine and the Ayurveda team, because their venue is what was utilized for this great function. And I think that more of a holistic based care is what is required at this point of time, especially the entire world is moving towards a holistic type of care, and Department of Integrative Medicine and their team members, from the head of their team as well as all the other members, I would like to place my thanks on record to the Department of Integrative Medicine as well. I would also like to thank our multidisciplinary team, that is the clinical psychology counterparts, as well as the psychiatric social work team. Both of them have actually contributed in great detail, not only with respect to seeing the patients, but also kind of helping us in understanding more about the psychosocial dimensions. So I would like to place and record special thanks to them. And I would also ask them to be a part of similar such programs in future as well. My also sincere thanks is to the administration of NIMHANS, especially Dr. Pratima Murthy, Director of NIMHANS, the head of the Psychiatry Department, Dr. Y.C. Janardhan Reddy sir, for providing support and encouragement. As well as I would also thank Dr. Muralidharan, who is the Medical Superintendent, the RMO, Dr. Shashidhara, all of who have been instrumental in kind of motivating all of us, as well as providing enough and more administrative support and help, which is actually required when you actually have a kind of taking care for patient with multidimensional needs. So it is very important that I should place in record the thanks to all of them. I would also thank the participants. There have been more than 500 people who have actually registered, and all of you have been active throughout the session. So it is indeed a great thing that all of you were there, even though the session ran half an hour more than what was expected. All of you were kind of active, and enough and more questions were also provided, which is a great thing. And I wholeheartedly thank you. And I would also request all of the participants to actually subscribe the Vayomanasa Sanjeevani YouTube channel, which is kind of giving a lot of practical aspects about care for elderly. Especially in the decade of healthy aging, it is more important that people become more and more aware about the newer aspects of care for patients with severe as well as major and minor mental illnesses in the elderly population. And finally, I would also thank the Icon Life Sciences company for actually supporting the logistics. And they were a very dedicated team, and they had supported in terms of providing the audiovisual support. And it is indeed a great opportunity that they have taken us, so that I think that their support would be there for future programs as well. With this, I thank the entire team for actually being part of this, and the administration also for providing the necessary support. And I would actually pass on the mic to PT sir for his closing remarks. Thank you.
I think we had got an overwhelming response. I also wanted to thank our coordinator, Gina, who was kind of able to coordinate this program and kind of making it happen without much of glitches. So, and all the participants and my team, entire geriatric psychiatric team, who have in a short notice, who had prepared and then presented, all the presenters, Dr. Aarti and Dr. Nandini, and I think these patients have been managed by a multidisciplinary team. So thank you one and all. Have a good day. Thank you.